This is The Express with Gary Allen, your 360-degree view of the world. Now, here's your host, Gary Allen.
Good evening, everybody, and welcome to The Express here right on TMV Cafe. Hearing a little bit of an echo. Would like to let you all know that we have a very interesting show for you tonight. We're going to be talking about Alzheimer's and dementia and care for those who care for the caregivers who care for those that have it. It is an insidious disease. But before we get into that, I just want to welcome all of you to The Express. I am Gary Allen. To all those that listen to us every week, thank you so very much, including Randy. I hope you're out there listening tonight. Want to remind all of you, if you want to check things out on Facebook, you can go to Gary Allen, A-L-A-N, at The Express. I've been informed by many that if you just go in and Gary Allen, The Express, that should pretty much get you there. I'm excited about that. There'll be some news about a new part of our website coming up pretty soon. Next week, Mark Viola will be back with us as we will be discussing headlines. But tonight we have, and he is on the line, Dr. Cohen from Compass Research. They specialize in a number of areas of medical research. They're one of the leading laboratories and research facilities here in the United States. Let me tell you a little bit about our guest. He's a graduate of the University of Pittsburgh, Bachelor of Science in Psychology. He went to the Chicago School of Professional Psychology, where he received his master's in clinical psychology. Also at the school in Chicago, he also received his doctorate in clinical psychology. He's board-certified rehabilitation psychologist and currently director of neuropsychology at Compass Research right here in Central Florida. I could go on and on and on about his resume, but it is impressive. And he and I have a lot in common. We've lived in a lot of the same cities, and he's one of the nicest gentlemen you're ever going to meet. By the way, Compass is one of the leading, as I said, research facilities in the country, as well as here in Central Florida. Dr. Cohen, welcome to the program.
Thank you very much. Glad to be here.
As I said a little bit, we're going to be talking about Alzheimer's and dementia. So let's get to it with this. And this is interesting. 1 in 3 seniors dies from Alzheimer's or another form of dementia. I'm just kind of setting things up here a little bit. Alzheimer's is the 6th leading cause of death in the United States. In 2015, Alzheimer's and dementia will cost our government $226 billion. By the year 2050, that number will increase to $1.1 trillion. And apparently, 2/3 of those that come down with it are women. And, of course, you're doing a number of trials or tests there at Compass. What about the rest of the world? Are there parts of the world, Doctor, where we're noticing there's not a large percentage of the population with Alzheimer's or dementia, or is it worldwide becoming a large epidemic?
You know, it's an interesting question. We look at meta-analyses of dementia studies, and we find that, in general, dementia really knows no bounds geographically. Really, it's demographically that's the issue. We do find lower numbers of Alzheimer's type dementia and vascular dementia, those dementias caused by multiple small strokes, in countries where there is a better diet, a Mediterranean diet, so to speak, higher unsaturated fat, in the diet and so forth. We see countries that utilize diets consisting of turmeric or curcumin have lower incidences, but it's not a hard and fast rule, and certainly we don't think that diet is the only factor involved in development, but it is one. But by and large, we're finding high levels of Alzheimer's as people grow older, and that's across the world.
But one thing that I found real shocking, and of course for all of you out there, if you're looking to get more information about Alzheimer's, Dr. Cohen turned me on to ALZ.org. That's ALZ.org, which is a wonderful website for you to find out about a myriad of things that are going on as far as combating this terrible, insidious disease of Alzheimer's, as well as dementia. Let me say this right now, that more than 500,000 Americans will develop Alzheimer's disease this year. And here's something I found interesting, and half will never be told by their doctors of the diagnosis. Why is that?
Well, part of the problem is that, your primary care physician has to do an awful lot. I mean, they have to understand, your metabolic condition, your everything from soup to nuts. I mean, and to be an expert in neurologic care, and to understand the nuances between old age and early signs of dementia, it's very hard for them to do that in the office by themselves. And so very few general practitioners really go out there and spearhead this issue of geriatric and neurologic functioning. Many times what happens is a family member will come to their doctor and then their primary care, and the primary care will say, well, look, I don't know for sure, so let's send you to a neurologist. The neurologist will then work you up and in best case scenario, send you to a neuropsychologist as well, and they'll come with a consensus diagnosis. But, a lot of people, Gary, by the time they get to the doctor, they really are in the moderate stages. And at that point, you don't need your doctor to tell you there's a problem. I think everyone around you is aware of it. So really in the early stages, what we would call mild cognitive impairment, sort of a prodromal or early stage, even to the mild to beginning of moderate stages, people compensate fairly well. And the doctor, really only has time to look at your blood pressure, how you're doing, globally. And unless someone makes a big deal about it, they may never be, really aware of it or address it.
Before we get too far with this, let's address what is dementia and what is Alzheimer's. And the second part of that is, how often is one diagnosed for the other, and it's a mistake?
Yeah. Think about the term of dementia as an overarching descriptor of cognitive impairment that gets progressively worse. We don't know why that is. It could be for a whole myriad of reasons. For example, it could be related to your vascular condition. It could be related to HIV. It could be related to something even as like syphilis. There's a lot of reasons a person could have a worsening cognition that's beyond the scope of what we would expect for someone's age. When you really nail down what's going on and you rule out a tumor, let's say, or you rule out, a diabetic condition or seizures or something like this, then you're left with this progressively worsening condition, and you have to typify what it is. Alzheimer's disease is just one form of many forms of dementia. And again, dementia just means a progressive loss in thinking ability, not just memory, over time, which causes functional impairment. So, if you go into a room and you forget something and you don't remember what you're going to say, and you forget your keys once in a while, those things happen to the normal person. They're not functionally impactful. They don't stop you from going to work or doing anything. They're annoying. But it's not dementia. But when you start to have these problems and they're getting worse, and they stop you from going out, maintaining your job, maintaining your relationships, really affect your mood, then we're starting to look at something that could be structurally wrong and progressively worsening. Alzheimer's disease is the number one, about 70% of cases, the number one most common type of dementia. But just telling someone you have dementia is not, that tells you, and if you really have a diagnosis of dementia, that just tells a normal person, look, I'm having problems with my thinking. But Alzheimer's is primarily a disorder of memory, where it starts in the brain. The telltale signs and the etiology of what's going on is also something that we have a pretty good handle on. So they're not synonymous. Although Alzheimer's is a type of dementia, just having dementia does not mean you have Alzheimer's.
I've also heard that what Alzheimer's is at its very serious stage, and I don't think there's anybody out there who hasn't seen or heard of a family member or a friend's family that it hasn't touched somebody's lives, about probably everybody that's listening in tonight. But I've heard that Alzheimer's is really like calcium, or the plaque that comes on your teeth when the dentist cleans your teeth. And that's the hard part. We can't get in there and clean it like we would when we go to the dentist to get our teeth cleaned. Am I simplifying that, or is that pretty much what that is?
The problem is we don't know if that plaque is the aftermath of a disease process, like the rubble, or that is the disease. We don't know. And so So if the audience could picture, you have a cell, which is basically a small structure, a bubble, and inside it's got a whole bunch of different things in it. And the cells are connected by wires, okay? And every person has a certain amount of amyloid plaque. Amyloid is a protein. It develops normally in people. And as you get older, you deposit some level of amyloid plaque in the brain, and that's pretty normal. Mm-hmm. But for some reason in people who develop Alzheimer's, that plaque buildup is really bad. And it starts to build up to such a degree that it gets in the way of the communication of the cells and the neurons. But more than that, and because if you look at a person who's over the age of, let's say, 70 or 75, they're going to have some amyloid plaque buildup. But not everybody with amyloid plaque buildup has Alzheimer's disease. Mm-hmm. So that can't be all it is. And then inside the cell, you have these small tubes called microtubules. They're made up of proteins called tau. And for some reason, these tubes that deliver nutrition through the cell, they start to bend and fold, and they morph, they mutate, and they turn into rubble. They collapse, and the cell dies. So inside the cell, you have this tau that is becoming mutated and folding in on itself and self-destructing the cell. And outside the cell, you have these amyloid plaques. Right. So at the end of the day, we have these two things that we see in people when we look at the brain, upon autopsy. Mm-hmm. This in Alzheimer's disease is usually situated somewhere in the middle of the temporal lobes, which if you kind of put your hand where your top of your ear is, that's sort of the middle of your temporal lobe. It's important to note that Alzheimer's disease primarily is a disease of the top of the brain. When you think of the brain, the cortex, which is the outer layer, mm-hmm. that's what's starting to decompose. That's what's starting to blow up and become inflamed and have the disease process. So those are two things we look at, and I think what we're trying to find out now is how do we stop this cascade from occurring? How do we prevent this snowball effect where there's a point where you just cannot compensate anymore for this worsening plaque and tangles, and it becomes what you know as Alzheimer's disease. Because mm-hmm. we think that the disease process starts about 20 to 30 years before people even are aware of it, much like in Parkinson's disease. Mm-hmm. So by the time you really show symptoms and you go to your doctor, a lot of this has started years ago. So the issue now is prevention. How do we prevent this from happening? And that's very complicated.
Do you see it, how it runs in a family? For instance, my one uncle had it. My one aunt had it. The two older, the brother and sister in my father's side of the family. But my Aunt Anne didn't have it. My father didn't have it. I mean, does it generally run in a family, but it will skip siblings along the way?
Well, we don't know. We don't know exactly. There is a concordance rate that's higher in families than as it runs through family, but it's not 1-to-1. Mm-hmm. Even in identical twins, let's say you take a monozygotic twin, which is an identical twin. You remember those old double mint commercials?
Right.
An identical twin is a person who is genetically identical to you. Mm-hmm. And when we look at the concordance rate of one twin having Alzheimer's versus another, what we see is that the inheritance rate is about 60 to 80%. So you say, well, that's kind of high. But, if it was just genetics, why wouldn't it be 100%? So there is still a 20 to 40% variance in that one. Is that it's not only your genetics, but what you do with your genetics, how you live a healthy life or not, mm-hmm. in terms of your diet or your exercise or the richness of your environment and your socioeconomic status and so forth, your education level. These seem to play a role. Now, in a study done by when I worked with Orlando Health as director of neuropsychology for many years, we looked at the state-funded memory disorder clinic. We found that if you have one person a first-degree relative in your family, so a mother, brother, sister, or father, the chance of you getting this disease strictly genetically was only about 11%. Mm-hmm. But they found that if you have two first-degree relatives, and it was a mother or father, mother and father, or a sister or brother and a parent, you had a 50-50 chance. And I think, and again, that's much higher, and strictly because if we're looking at genetic variables, there's no one more similar to you genetically than your siblings. So if you have a parent and a sibling with this, you have a pretty high chance of developing. Now, we should also let the audience know that, there's different types of Alzheimer's disease. There's different, if anybody has watched Still Alice or read the book, you'll know that there is a pre-signaling 1 and a pre-signaling 2 gene. And these people who have this gene tend to develop dementia much earlier. So when we talk about early onset of Alzheimer's, we're talking about pre-65 years of age.
Yes.
When we talk about late onset, we're talking about, 75 and plus. As you get older, the chance of you developing some form of degeneration goes up pretty high. In fact, over the age of 85, 86, the chance of having some kind of cognitive impairment is 60%. It doesn't necessarily mean it's Alzheimer's. But we're really talking about, people who are much younger developing this in their 50s and 60s. And in fact, the first documented case of Alzheimer's that, Eloise Alzheimer, the famous neurologist who discovered the disease, was in a 55-year-old woman. Genetics are part of it. We are looking at the genetic loading, but it's not all of it. It's not all of it.
And when you talked earlier about diet and exercise and your mental environment, have you come to any conclusions yet about, you said about the Mediterranean diet, and then you also talked about your environment as far as how you use your brain and reading. And I've heard and then seen on television from doctors that say we've seen patients who are extremely active mentally, and other doctors and lawyers and people who have used their cranium, their gray matter for a lot of years, and we've also seen people who are just blue collar people who maybe read a book every once in a while or just read the newspaper, that are not using their brain on a consistent basis for their income. Someone who's a white collar compared to a blue collar. Is there any distinction with that yet, or is the research still up in the air on that?
Well, I think there's different theories depending on the way you look at the research. There's something that we call cognitive reserve. And cognitive reserve is putting down networks of pathways in the brain and using them so often that you create much larger, more robust roads, so to speak. And the more and the thicker that these pathways are created, the more you can stand to lose before you start to have a problem, And so obviously if you have kind of an impoverished upbringing and you haven't really, you've used your brain, but certainly have not used it to its fullest potential, or really, challenged it, stressed it out, and have been educated, maybe less of those pathways have been put down. And so even, just education, mental stimulation, those things are helpful in building a more robust brain, right? But that's not the whole story, too. We also look at what is the impact of poor cardiovascular and cerebrovascular health on someone's brain. And we know that the link between obesity and diabetes and Alzheimer's disease is very, very high.
How about smoking?
Very high.
How about smoking?
Absolutely. Well, you have to think of it this way. Pure Alzheimer's disease is very rare. And there's a study done back a few years ago by Snowden, and he looked at nuns who had agreed to have their brains donated upon their passing. And the nuns that showed evidence of memory loss and dementia before their death, when they looked at their brains, they did find amyloid plaque, as they would have predicted, but they also found vascular wear and tear, stress marks, cerebrovascular wear and tear, meaning that, there is a strong link between your cardiovascular health meaning your heart, your plumbing system, your ability to maintain a non-inflammatory environment, meaning that, people with diabetes, their brains have too high levels of sugar or too low levels of sugar. It inflames the brain. So we're finding now that exercise is probably one of the most underutilized, forms of prevention of cognitive impairment for lots of reasons. Exercise, it lowers. It's the first line of defense against diabetes. And so if we know that diabetes is highly related to Alzheimer's disease, we got to keep diabetes down. Hypertension and high cholesterol are also affected by exercise. So you have this link that you can't take away, this link between the plumbing system in your body and up to your head and the laying down of amyloid plaque. And true enough, like the calcium you're talking about, the higher your levels of cholesterol, it seems it's not the same plaque, but it does seem to put down more amyloid plaque in the brain when you have higher levels of blood cholesterol. So we have these links, and we know that exercise helps. Now, somebody who exercises a lot and has a lot of education and has a lot of access to resources and, so on and so forth, they may still develop Alzheimer's disease. And the question then is, or the argument would be, well, they allowed themselves to, they gave themselves the best they could. They staved off the disease as long as they could.
What about head trauma? We were talking about that the other day on the phone, as far as with like NFL players and soccer players, because I know you have a great deal to do with our soccer team here in town. But what about head trauma in general, from automobile accidents, what have you? Does that induce the disconnect with the Alzheimer's and dementia too? Does that increase the disconnect in the brain?
Well, any trauma to the brain obviously is not good. And I think over many after multiple traumas, there is a relationship, a positive relationship, in the sense that the more head trauma you have, the more predisposed a person would be for cognitive impairment down the line. But don't get me wrong, folks. If you have a concussion, back in your high school era, that does not mean you're going to develop Alzheimer's. But you're pushing the ball a little further down the road in terms of having problems later on. It's kind of like having multiple orthopedic injuries in your youth. Chances are you're going to mechanically be having problems when you're in your 50s and 60s because you didn't take good care of your body early on.
Right.
And we're not talking about having a bump on the head from, standing up and hitting your head on the cabinet, or even just having one head injury from a car accident necessarily. But we're talking about, multiple repeated concussions. And when it comes to the NFL or the MLS or NBA or even MLB, the issue is that when you have a concussion and you don't let your brain rest and you continue to have multiple concussions, there seems to be it seems that it causes or contributes to having problems down the line. Now, it's a very controversial topic, Gary, this issue of chronic traumatic encephalopathy. That's what we're finding in the NFL. People are on the fence about whether it's a real thing, not a real thing. It looks a lot like Alzheimer's disease, but the plaque is deposited in a different place. We see it in much younger people. So we can't get into that tonight, but the issue of does multiple head injuries contribute to problems later on, I think the answer is probably yes. Okay. But we don't exactly know the mechanism, and that is the same for every person.
Let's state this up front, because I think it's something very, very important for people to understand. A question that I posed to you the other day: if you are diagnosed with Alzheimer's and it becomes, and obviously it must become severe, I suppose, it more or less is what's going to bring your life to an end at some point, is it not? Through a period of shutting down different parts of your body. It's sort of like AIDS, if I can use that as an example. You don't necessarily die from the AIDS, but you die from the complications of what AIDS causes within your body. Well, the Alzheimer's has very much the same effect on your body. It starts to shut down organs and your respiratory system, and that's eventually what you probably die from: pneumonia and finally death.
I think in some cases people live long enough and the Alzheimer's may spread so far, but by and large, the people pass away from complications related to the cognitive and neurologic deficits that occur with Alzheimer's disease. For example, forgetting to swallow, or making a bad decision, or just not eating. Period. To become medically anorexic. It's really because Alzheimer's starts where it starts. It doesn't really hit the motor part of the brain until much later. Eventually people become mute. They can't understand. They can't speak. They can't visually discern what's going on because it affects the visual cortex. It may start to affect their ability to use objects. I mean, really, they become completely dependent. And this is in profound Alzheimer's disease toward the end. And at that point, there's many other things like neglect of care that get in the way. And I don't know that it's the Alzheimer's disease that eventually stops. In many cases, that's not the case. Or that is the main thing.
What are some of the early signs that people can look for in a loved one, or they've already seen it, and how can Compass help? And where do you recommend caregivers, because it's a frustrating time for them? I know, as I told you on the phone, when I sat across from my Uncle Jim, who had a brain that was sharper than he could add up columns of numbers, and he's sitting across from me and didn't even know who I was or didn't know who his brother was. Where are some of the places that people can, A, look for the early signs, and B, go to get help as a caregiver to understand this insidious disease and what it's doing to their loved one? Because I'll be honest with you, I took care of my mom and dad for 10 years, and there were days, and I loved my mother and father with all my heart, but boy, there were days, and neither one of them had Alzheimer's, but there were days when I was just running on thin, if you know what I mean. I was frustrated and angry that I couldn't do more. But what should people look for besides the forgetfulness and stuff? And where can they go to get help other than alz.org? And how can Compass help with that?
Well, so the first thing is I can answer about early stages. The problem is, and I think a lot of people will resonate when I say that this business of normal age-related decline is something that is very real. You can't compare if you're in your 50s. You cannot expect that your processing speed of information or your memory is going to be on par with someone who's 18 or 20. Right. And we don't. And age is the number one predictor of memory. And that's a huge mediator or moderator for memory. So there is a real thing of normal age-related change. As you get older, your memory does change a little bit. Your language processing changes a little bit. Your processing speeds change a little bit. But it should not be precipitous. Now, and it should not get in the way of your function, right? So we define normal age-related changes as the expected rate of change in different thinking areas. Without functional impairment. There's this condition, though. You don't wake up in the morning with Alzheimer's disease. It's a slow, insidious process, and it starts out with what we call benign forgetfulness, and it turns into something more. So, aside from memory loss, what we're talking about memory loss is episodic memory loss, which is the loss for details of episodes in your life, much like watching a television program. The who, what, why, when, and where. So who were we with? When did we do it? What did we do? There may be like confabulation where you're making things up or you're filling in holes and gaps. But more than that, when in the very early stages, it's hard to know whether those changes are because of poor sleep, which is a huge issue with all Americans. I mean, sleep issues account for a tremendous amount of cognitive problems and memory loss, including whether it's a medicine interaction, whether it's a urinary tract infection, whether it's something like depression. I mean, there's so many things, but in the early stages, it's hard to say. And when it starts to impact you day to day, then people will come to the doctor, and what we then have to do is figure out whether there's a measurable change in ability. And so if you go to your neurologist, the first thing your neurologist is going to do is they're going to take a look at your head. They're going to do a neurologic exam, take a history, and they're going to try to rule out stuff that could be going on, like something like hydrocephalus, where there's a blockage in the ventricles, or there's a tumor, God forbid. The neurologist is there to not only figure out what it is, but what it's not, right? God forbid if there's a cancer or something spreading through. Once they do that and they still haven't kind of earmarked what's going on, then they'll send it to a neuropsychologist. The neuropsychologist, such as myself, will do standardized testing, and that testing will be able to figure out for a person's age and education and potentially race and gender, what is normal for that demographic. And if they're not normal, how far above or below normal is that person? And when they fall in that mild range, but still their function's pretty good, we call that mild cognitive impairment. And mild cognitive impairment comes in two flavors. The first flavor is the memory loss flavor called amnestic MCI. And the other one is non-amnestic, meaning that there's some other problem that is impaired. And that could be speech, it could be processing speed or visual spatial skills. It seems to be that people diagnosed with amnestic or the memory loss flavor, that we really are starting to think that is the earliest stages of Alzheimer's disease specifically. Now, in that stage of the game, people are aware they're having problems. They're trying to compensate. They're sort of having varying success. They're repeating themselves or having a hard time maybe navigating like they used to, again, like they used to, not necessarily if it's an old issue for you. They may have a hard time finding words, and it's happening more often, and it's embarrassing. And at that stage of the game, you're still not going to see a problem on an MRI related to Alzheimer's. About 30%. About 30% of people with amnestic MCI convert over to Alzheimer's disease within a couple of years. So each year, you increase your risk of converting, and it's not until there's functional impairment where you really just can't do anymore, and it's really obvious that you hit that really mild to moderate stage. Now, the reason that I'm saying I'm focusing on this mild to moderate business is not because there's not care, but right now the medicines we have are not good. Okay, they're not disease modifying. They're not fixing anything. They're giving your brain what we think is a chemical that is in short supply, like acetylcholine, which is a neurotransmitter, or it might be a glutamate inhibitor, or something to help reduce some of the noise. But these medicines slow down the symptoms, but they don't stop the disease process from continuing its march.
Right.
And the reason we say is we know that the earlier you get on this medicine, the longer you're going to have, your longer your function is going to last. So early diagnosis is very important. Once you get into that moderate stage, we really have a hard time managing it. And as you mentioned earlier, we're really relying on the caregiver to talk to us about what's going on because, to be honest with you, and not to be comical, but people with Alzheimer's disease in that mild to moderate stage, they're forgetting. Mm-hmm. So when they go to see the doctor says, "How are you doing?" They say, "I'm doing great."
Yeah.
So the really early diagnosis is key. But
where can people go? Caregivers. Their loved one, and they're starting to see the diminished capacity that they're able to think, and they're forgetting, and it can be frustrating. Where can people go to get information and education? And let me read this one thing, because Hope for Alzheimer's Act is introduced to improve coverage and access to critical care planning. The Alzheimer's Association strongly supports the bipartisan healthcare outcomes planning and education Hope for Alzheimer's Act. Although Medicare already provides coverage for Alzheimer's disease diagnosis services, it currently does not provide coverage for comprehensive care planning following a diagnosis. The Hope for Alzheimer's Act will ensure newly diagnosed Medicare beneficiaries and their caregivers receiving comprehensive care planning services, and will require their diagnosis to be documented in their medical records. And David Hyde Pierce, the actor, was very responsible for helping this come to fruition. And by the way, Social Security, doctor, now also recognizes Alzheimer's as an impairment although it's very difficult to prove. I mean, it's not something easy. But there is this HOPE Act. Where do people go other than alz.org to help? Are there groups in your community? Are there organizations throughout the country that people can call and say, hey, I need some help. I got a patient here, a loved one, and I just don't know how to handle this. Where would you recommend that they go, and what will they get?
Well, the first thing is it has to start at the local level. You need to find a state-funded memory disorder clinic, and the reason I say that is because diagnosing Alzheimer's is not a one-stop shop. It's very hard to find one doctor who's going to do the whole thing and have all the evidence they need to make the insurance company convinced that they have Alzheimer's disease. And so when you go to a comprehensive care center, we have one at Orlando Health, which I'm affiliated, and they have community liaisons that they work with. They have social workers, neuropsychologists and neurologists, and other rehab professionals, including audiologists and speech therapists to kind of help get a clear picture. From that point, then it's a matter of resources in the community getting involved in their supportive groups. There's lots of different options, not the least of which is clinical trials, which I can bring and talk about later.
Yeah, we're gonna get into tomorrow. We're gonna get into the tomorrow study real soon here.
Yeah, but Share the Care is a wonderful organization that is completely designed for the caregiver, because as we know, caregiver burden and burnout is a huge cause. It actually reduces the lifespan by several years in caregivers. And, you're kind of tied. What are you going to do? But it does actually reduce your lifespan. And, of course, if someone is sick who's a caregiver, they can't provide good care to the patient, and they may become patients themselves. So it's a very difficult thing, but Share the Care is a wonderful organization in Central Florida that provides respite services, education, and real help for people who are caring for a loved one with Alzheimer's disease. We have the Alzheimer's Resource Association. There's several communities, and actually one of the nice things that Compass started not long ago is the Memory Care Coalition Group, which my associate Lisa Ede did was she got all of the memory disorder clinics and community, in-home care services and so forth together as a consortium to talk about what is the best, plan of care. So it's exciting for Central Florida to have that. But ultimately it's reaching out into the community, and every city is a little different, but yeah, that's the key, I think.
And, of course, they can get a hold of everybody at compassresearch.com, as I did, and they can reach out to you folks and get it. I just want to go quickly so we can get into this study, the tomorrow study. Here's some of the myths, Doctor. I'm just going to go through, let's see. Memory loss is a natural part of aging. From what I understand, no, it's not.
Well, like I said earlier, some level of memory, slowed memory or less efficient memory is common, but memory loss, as we think about it in terms of senility or real amnesia, no, that is not true. And I think a lot of people will attest to the fact that they've had family members who lived into their 90s. They were sharp. They say sharp as a tack. Right? So it's not a normal part of aging per se.
Here's one that I laughed at: drinking out of aluminum cans or eating from aluminum pots and pans can lead to Alzheimer's.
No, aluminum toxicity is a very interesting topic, and it's not really a conspiracy issue, but it is a heavy metal, and it does accumulate in the brain. But the amount that you get from wrapping your sandwich into aluminum foil or drinking soda out of a can is so minuscule, and there's just no studies that support that. Now, is it good for your brain, aluminum? No, it's a very small molecule, but there's absolutely no evidence proving in any way, shape, or form that aluminum foil or aluminum in the way that we use it is it is a very abundant element, but it is certainly not the cause of Alzheimer's as we know it today, at least as far as we know.
Right. Aspartame causes many losses. For those of you out there, that's your artificial sweeteners in coffee and soda and stuff. That's not true.
No, again, when you use rat models to try to predict what's going to happen in a human being, it's very problematic. I mean, this is why, for better or for worse, we test on different types of animals, because it's very hard when you get a good response or a bad response in a rat, or a mouse model, that it's not the same thing for a human. And loading up a rat with any chemical over many long periods of time at toxic levels, was bound to create an effect. But again, there is no study that shows that there's a direct link of Alzheimer's disease, multiple sclerosis, fibromyalgia, any of these things with the use of aspartame. Could some people be sensitive to it? Absolutely. Could there be some effect that we're not aware of, contributing to some kind of problem? It's possible, but there's just no evidence. So unless you can have a controlled study where you show a real effect size, you're just scaring people.
And the last one here, flu shots increase your risk.
No, absolutely not.
No, I didn't think so.
Again, more people are killed by the flu every year getting the flu. I mean, it's thousands and thousands of people die every year from getting the flu. And thousands and thousands of people every year are not getting Alzheimer's disease because they get their flu shot. It's just not possible.
And one last little news item before we get into the tomorrow study. As I said earlier, for people that are contracting and diagnosed with Alzheimer's under the age of 65, the Social Security has identified for early and younger onset of Alzheimer's a list of conditions in which you can get compensated an allowance for interactive disability insurance. So Social Security is slowly catching up to the medical research too, and they're realizing that people are getting Alzheimer's at a younger age, and you can now be compensated for that. But it is very difficult, from what I understand, to prove with the Social Security Administration. Now, let's get to your baby here, to the Tomorrow study. Explain to everybody what the Tomorrow study is at where you are at over there at Compass.
Okay. So let me just say, to back up just a foot or two. Compass Research is a clinical trial site, so we are not a pharmaceutical company. We work with pharmaceutical companies over many, many trials. We have over, well over 100 trials, clinical trials from different pharmacological companies. And our job is to run a protocol to their specificity, and do it well and get good data, and just really follow the rules. And in doing so, we're learning so much about, about 60% of all of our trials that we have at Compass have to do with neurodegenerative function. So many, many trials on mild Alzheimer's, moderate, and severe, and some really neat diagnostic procedures that are kind of getting around the issue of diagnosing Alzheimer's better. So we do a lot of work, and we employ a lot of full-time doctors there that specifically have an expertise in Alzheimer's disease. So that's what we do. We run these trials. We're not necessarily providing treatment like you would get, at your GP's office, but we are providing, if you get into a clinical trial, we are providing diagnostic services and tests that you probably would not have access to due to cost or otherwise, in general community. So,
but let me interrupt here real quick. But if you were to diagnose someone in this research with Alzheimer's, and you really saw that this person was really going to come down with it, you would certainly, I would suppose, knowing you as little as I do, but as ethical as I think you are, and I know you are, you would certainly say, I think you better go see your primary physician, because here's what we have found out through the research.
Well, absolutely. So here's the thing. So when you get involved in clinical research, we ask that you sign a release that be able to talk with your doctor. In the street, it works two ways. Number one, in order to be in a certain study, we have to be able to prove that you are the medically functioning person that you say you are. We have to be able to essentially exclude people from studies that have certain medical conditions and include others that have some. So we have to work with your doctor to find out that information, and they want to know from us what we're finding. So an MRI, can be very expensive. It's free at Compass if it's in the study. A PET scan can be exceedingly expensive. and it could be free as part of treatment. Blood work, and neurologic exams and so forth. Neuropsychological testing is very expensive. So there are benefits to that. But absolutely, if we find out something or we feel strongly clinically that there's this problem, we're on the phone with your doctor as soon as we can. But before we do that, we discuss those findings with you, because this is research is always confidential, always, and it is and it should be mutually beneficial, not just to us to be able to study you, but also but to you. It should be beneficial. It should be very helpful. So, aside from the money we pay to reimburse you for your travel expenses, we want to be able to provide you education.
So tell us a little bit more about it as far as the MCI part of it, and due to AD. Explain what MCI is and what AD is.
Okay, so we already talked about normal age-related decline, and then we said that the next step as you transition from being what we call normal, right? It's, again, no big changes compared to people your age, is something called mild cognitive impairment that we talked about. So, and that's the mild cognitive impairment due to Alzheimer's disease, which is the earliest phase of Alzheimer's disease. So if you're diagnosed with MCI due to AD, that means you have been diagnosed with probably one of the earliest phases of Alzheimer's disease. Now, the Tomorrow study is looking at people who are currently cognitively healthy, right? These are adults between the ages of 65 and 83. And we are studying people who, based on testing, are, and on medical records, are pretty healthy. There's a couple exclusionary factors, but by and large are healthy people. But doing the genetic testing that we do, they may have a higher risk of developing Alzheimer's in the future. The genetic variables we're looking at are not biomarkers. I repeat, they're not biomarkers, meaning that if you have test positive for these genes, it doesn't mean you are going to you will be developing Alzheimer's. It just means that you're at a much higher risk. So we are looking for two specific genes. One of them is called APOE4, and you might get one from your mom and one from your dad. There's basically three genes you can get: a 2, a 3, or a 4, and you get one from mom, one from dad. So you're some combination of 2, 3, or 3, 3, and 4, 4, 2, 4, and so forth. That when you have a 4, 4, it increases your risk considerably of developing Alzheimer's, but doesn't mean you're going to get it. And not having that gene doesn't mean you're not going to. Not having it doesn't mean you're not going to have it. So that, in combination with something we call the TOM40 gene, which is the beginning of the word tomorrow, those two genes together seem to predict the development of Alzheimer's disease very highly. But again, to the audience, it doesn't mean you'll run out and get a genetic test, because it's not going to determine that you are absolutely going to get it. So we're studying these people who are normal now but have the higher risk, and we're following them with neuropsychological testing, this standardized testing, for 5 years. And this study, unlike any other study that's ever been done, it is looking at prevention, possible prevention of Alzheimer's disease, and looking at a medicine that's already on the market that is an anti-diabetes medicine. Because remember, we talked about the high comorbidity or the incidence of diabetes and Alzheimer's, right? So, and the way the body handles and metabolizes sugar. So, not to be overly technical, but we're using this medicine to see if we can possibly prevent the buildup of amyloid plaque and the destruction of the cell. So, this is a study that is worldwide. I mean, it's in Russia, it's in Australia, it's in England. We have it in different Spanish-speaking areas, and so the tests have been translated. It's worldwide, and Compass alone is trying to recruit more than 5,000 participants. Right now we've already screened close to 2,000, because there's a high fail rate. But there's 50 to 60 study centers in North America, Europe, and Australia. And And it's a fascinating study because we're looking at someone normal, and we're hoping to keep them normal over 5 years and not see them decline. But if they do decline, we are the first to pick it up. And that really is the benefit of being in the study.
If someone is listening in right now and they can contact you, contact compassresearch.com, what is the time commitment involved for these individuals? Let's go through some of what it will take on their part to be part of the research study. Say someone's accepted. What are the things that what's the time commitment involved in this?
Well, it's not very much. I mean, I would say that it's, you're going to be giving up about 3 to 4 hours every 6 months. And we are compensating you for your time, and it's a highly educational process. But let me just say that because we're looking at this one genetic type, only about 12% of people get into the study. We have a lot of studies running at Compass, but for this study in particular, only about 12% get in. If you do get in, you're going to come in, we're going to interview you, we're going to find out more about what's going on. Do you have any problems? You should not have dementia coming into the study. If you come in and you say, Dr. Cohen, I've been diagnosed with dementia, you can't be in the study. You can't have the diagnosis of that. But you come in, we look at the medical records, we take some blood, we look at your genotype, excuse me, and then we do a baseline assessment and see where your brain is. Excuse me. We do an MRI. We might do other scans, but the time commitment, for the first visit is a little longer, but subsequent visits are a few hours long, and we're keeping track of you every step along the way. So for really every six months is when you would be seen, and snowbirds can apply because they might go away for 4 months or something and come back.
What about people that are already on medication? How does that work as far as interacting with the medication in the study?
There are a few medicines that will not go with what we're doing. You can have diabetes, and you can be on 2 medicines for diabetes. You can't be on 3. You cannot be on a study drug. So if you're on Actos currently, pioglitazone, you cannot be in the study. If you're on any medicine for memory loss, Aricept, Namenda, Exelon, you cannot be in the study because a doctor's already put you in because they thought you had memory loss. There's some antipsychotic medications you cannot be on, and if you have Parkinson's or multiple sclerosis or any other type of neurologic disease like that, you can't be in the study. But we would look at all your medicines and figure that out, and so you don't have to worry. We will ask you all those questions.
Are you at the clinic constantly in contact with the different people that are part of this research study? In other words, who's taking care of these folks? I would assume they're regular doctors since you'll be in touch with them, but who cares for these folks while they're going through the study?
Well, their medical care is always handled by the primary care physician or the neurologist. So we're not providing them regular care. We can serve as a conduit. If they have questions, we call them. We are always asking for updated records. When you come in for your 6-month study, we say, listen, bring your study medicine in, bring any new records. If you've had any surgeries or hospitalizations or bumps, slips, and falls, we have to know all about that. If you're having any side effects, if you're having any changes in your thinking. One key thing I want to stress, which I didn't bring up before, is the neat thing about this study is really recruiting 2 people at once. The person that is perhaps worried about their family lineage and maybe themselves a little bit, but also there's a study partner which comes with you every visit. It could be a spouse, a sibling, a best friend, somebody who knows you really well, and we need to have that person there to be able to validate whether or not they see any changes in you. Because as we said earlier, people with significant memory loss forget that or minimize what they have. So we also need the help of a study partner. Very, very important, Gary.
I know that people are going to laugh at this question, and maybe you will too, but how important are studies like this, not only just for Alzheimer's and dementia, but in general when it comes to medical research? How important are getting people to come in and participate in order to get to the bottom line of how to help people live a long and more beneficial life?
I mean, there's just no way around it. You think about when you go into your cupboard or your medicine cabinet and you look at the medicines that are in front of you, and you put a lot of faith that these things are going to work. You have a headache, you take Tylenol, or you take ibuprofen. You get sick, you take an antibiotic or whatever. And the reason we know these things work is because we proved they work, but we didn't prove they worked overnight. And the studies are rigorously tested. There is just no way to find these cures without assistance. Now, some people get involved in my study because they want to help their greater man, womankind. They want to do their part. Some people do it for themselves. But whatever the motivation is, you are always helping other people by forwarding the ball down the field. And because Alzheimer's disease is such a terrible disease that's only getting more prevalent as people age and as our population ages, we have got to find a cure for this. It is an epidemic.
Yeah.
So it is studies like this, prevention studies, where we're actually studying people who are not sick, are really, I think, the key and the new wave of research.
Yeah, because I said
genetics.
I don't know if you heard me or not, but at the top of the program, I talked about that it costs $226 billion this year for research, and by 2050, it's going to be over $1.1 trillion in medical research and also the care for patients with Alzheimer's. Are you finding that the stigma of Alzheimer's is starting to be lifted, and we're starting to realize more and more people are coming down with this? And the statistic that caught me off guard was the one that people before the age of 65 are developing this. And, of course, you said earlier in the program, people in their 30s, 40s, and 50s are developing this. I mean, is it starting to resonate with people, hey, we've got a problem here?
Yes, I think because we're starting to understand that the earlier stages, we used to say, something wasn't right about him or something, they fell off their rocker or they became senile later on. People were not thinking of the term of Alzheimer's or what that meant, or that it was something that had a definitive time and date that it started. So awareness is important because we don't want to put our heads in the sand.
Right.
The scary thing, though, Gary, is that at this point in the game, we still don't have a panacea. We still don't have a cure. We haven't, there's been a few documented cases of the Alzheimer's reversal by very, very strict dietary and behavioral regimens. And then, of course, you sort of wonder whether they had Alzheimer's to begin with. But at the end of the day, it's still scary because we don't know, how to cure it. And so people would rather not talk about it. But I think, as the population ages, there's no choice. We have to talk about it. It is exceedingly rare to develop Alzheimer's in your 30s, 40s, as a clinical manifestation, But we have seen it, what we're better at doing now is detecting this in people in their younger, their mid 50s and so on, with the techniques we have today, the diagnostic techniques, and we're about, I would say, with PET scanning and neuropsychological testing, we can get to about 98% accuracy without having to do an autopsy. We can get very close to diagnosing Alzheimer's in the earlier stage.
With the final minute that we have left here, what's your recommendation to people out there who are a little scared or a little worried about Alzheimer's? They've seen it in their family. What do you recommend? Like I said, we have about a minute to go here. What do you recommend for them to do?
I would recommend that you get an early workup, a baseline done now, because at the end of the day, you've got things you want to do. There's plans you want to make, and not knowing can be very damaging to not only you but your family. So I would say if you're concerned and you want to work up, Compass Research can help you with that. And evaluate and see what we can do. But at the end of the day, you really need to get educated. And who knows, in a lot of cases, we're able to say, you know what, you don't have Alzheimer's disease. You have depression, or you have a medication, you're over-medicated, or you have a dietary or a metabolic issue. So sometimes you're worried about Alzheimer's, and it's not Alzheimer's. But you're not going to know that unless you go in and you get evaluated.
Dr. Cohen, I thank you so much for joining us here tonight on The Express. I'll be in touch with you very, very soon. Ladies and gentlemen, that's Robert Cohen. He is the Director of Neuropsychology at Compass Research. Please contact them at compassresearch.com. Thank you so much, Doctor, for joining us tonight.
Thank you very much. It's been my pleasure.
And for all of you out there, I thank you so much for taking a few minutes out of your day to join us here on The Express. Don't forget, next week will be Headlines with Mark Viola. You can catch me on Facebook if you have any ideas. You just want to say hello or be a friend at Gary Allen, ALAN, at The Express. And again, thank you all very much for taking a few minutes out of your day. I appreciate that very, very much. Until next time, please take care of yourselves and each other.
You've been listening to The Express with Gary Allen. Join us here every Tuesday night at 10 for more captivating talk with Gary Allen. See you next time on The Express.